Arthroscopy is nothing new. It has been done for the past many years. So initially hindfoot scopy was done by the anterior-lateral, developed the prone position, two posterior-medial and the posterior-lateral technique. So since then it has been followed commonly, and I am also more used to this approach for doing a hindfoot arthroscopy in the ankle. So the standard approach for the posterior pathology in ankle in arthroscopy are for basically these three important indications: to look at the posterior ankle compartment, to look at the subtalar joint, and to look for any extra-articular structures like the stata process or the FHL tendon, which we follow in FHL tendon transfer for a Haglund or a chronic tendo-Achilles rupture, and also for Haglund exostosis. So the preparation for the surgery is quite simple. You should put the patient in the prone position, and the basic 4 mm 30-degree scope is used with 3.5 mm shavers, and 3 to 4 mm bone curettes and osteotomes are used. The patient positioning is shown in the diagram. You put a small bump, and the heel should be free from the distal part of the table so that you can do at least 90-degree range of movements. And your portals are made just at the level of the distal tip of the fibula, just lateral to the tendo-Achilles tendon, and similarly at the same level, just medial to the tendo-Achilles tendon for the posterior medial portal. So here is a diagram where you can see the positioning for the portals. And first we go through the posterolateral portal and look at the joint. So first what we do is we put the scope and we touch the bone. And the posteromedial portal is literally a blind way, so we don't use a needle. We make the portal, we dilate it, and we try to open up the capsule from posteriorly, and then we take a blunt instrument, either a shaver which is not rotating, and try to touch the distal tip of the scope, which is facing laterally, so that we don't scratch the lens. And then we try to come proximally towards proximally and take it away, take the camera away from the shaver so that now we can visualize the shaver. So then we start cleaning up the soft tissues, the capsule, the crural fascia. And the most important is not going lateral to the FHL tendon to avoid any neurovascular injury. So this is a short video where I would just like everyone to identify the FHL tendon. So it is important to identify it initially and not go medial to it. Try to stay lateral so that you don't, to avoid any catastrophic complications. And I use mostly a curette and a shaver. I don't use osteotomes to prevent any bone loss. So this is just a small video snippet showing the preparation of the joint. So once the joint is prepared, you inspect the whole joint and you clear out all the cartilage from the posterolateral to the posteromedial, anterolateral to the anteromedial direction. And after clearing out all the cartilage, you can pass your guide wires, and of course you can try to see the guide wires through your scope for its positioning, but it is always better to check through a C-arm for the positioning. And it is also important to wash out all the loose bodies and the debris that you have cleared out from the joint. So once you have put your guide wires, you can pass your screws. Some people like to see the compression, pull out the scope and see the compression while it's happening when you're tightening the screws. But I don't think it is very important. You can always use the C-arm for one or two shots. And yeah, so the advantages of doing a arthroscopic subtalar fusion or an arthrodesis is obviously less soft tissue injury and preserved vascularity to the calcaneum and the talus, less pain, proprioception is spared, less chances of infection, high union rates, and early weight bearing. However, literature-wise, there are very few articles which mention clear-cut advantage over an open technique, and some few articles are there which mention that it is as good as an open technique, if not better. So the limitations can be hindfoot scopy is a little difficult to start with. It has a steep learning curve, and of course it is contraindicated for a deformed hindfoot. If you have a malunited calcaneum or a deformity in the hindfoot, this is not the best technique to do a subtalar fusion through scopy, because you cannot correct the deformity. You cannot use a bone graft, and of course no clear benefit over open technique. Thank you.
Shakti. Hello. I have got one question.